So my name's Reshma. I'll be giving the talk today on respiratory emergencies, cancers, lung cancers, pleural effusions, TB and sarcoidosis. So it's quite a few topics to get through. If we just begin. So we'll start off with respiratory emergencies. So there's 5 main ones that we're gonna cover. There's one that I'm not covering, which is pneumonia, and the reason why I'm not doing that is because I believe you guys are having a talk on pneumonia anyway, so I feel like a lot of that will be covered in that session. So what we'll do today is we'll talk about managing an acute exacerbation of asthma, managing an acute exacerbation of COPD, pneumothorax, tension pneumothorax, and also pulmonary embolisms. Okay, so before we go on to speak about managing an acute exacerbation of asthma, it's important to know how we grade an exacerbation when it comes in. So with asthma, you'll know it's a chronic condition, but what can sometimes happen is you can get an attack, obviously, where the symptoms that you get with asthma are increased. And so the features of an attack are having a worsening cough, dyspnea, so like difficulty breathing, a wheeze, and being unresponsive to your salbutamol inhaler. So those symptoms that I just listed are things that you usually find in asthma, but like I said, they're increased in an acute exacerbation. So the way that it's graded is based on the person's rest rate, their heart rate, and also their peak expiratory flow. So that's something they can monitor themselves at home. And you say that someone has a moderate asthma attack if their peak expiratory flow is greater than 50 to 75% of their best. So they'll know what their best level is, and if it's 50 to 75% above that, then that's a moderate asthma attack. And also, if it has no features of an acute severe asthma attack, then you could say that's a moderate attack. An acute severe attack is where their peak expiratory flow is between 33 to 50% of their best. If their rest rate is more than 25 breaths per minute, or if their heart rate is more than 110 beats per minute. And a way that you can usually tell is if a person is unable to complete a sentence without getting out of breath, they're having to take more than one breath to complete a sentence. A life-threatening asthma attack is, a handy way of remembering it is 3392 chest. So it's if their peak expiratory flow is less than 33%, if their SATs are less than 92%, if they're cyanotic, so if they've got like blueness around their mouth or the fingertips, if they're hypotensive, so if their blood pressure is less than 90/60, if they're showing signs of exhaustion, if they have a silent chest, so when if you're listening to their chest you're not able to hear any breath sounds, that's usually a bad sign, or if they're tachycardic or bradycardic. And then the final one is near fatal asthma attack, and that's basically got all the features. It's got the features of a life-threatening attack, but on top of that they also present with hypercapnia. So if someone has an asthma attack, they're going to be breathing very fast. So when you breathe fast, you expect to be blowing off carbon dioxide. So what you might find is if someone has a very severe asthma attack, instead of their carbon dioxide being low, which is what you'd expect if someone's hyperventilating, it's paradoxically high, and that's usually a very serious sign, and that's something that you'd really worry about. Okay, so managing an acute exacerbation of asthma. So if someone was to present with like a history of asthma and they've come in with wheezing, breathlessness, the first thing that you do in this scenario before you even know what it is an A to E assessment. So in your A to E assessment, you'd go through, so you do airway. If their airway's fine, you'd move on to breathing, and that's where you'd usually find most of the signs that would alert you that it's an exacerbation of asthma. So their rest rate, you take their rest rate, you'd listen to their chest as well, take their O2 sats. As part of the AT assessment, you'd also check their heart rate, blood pressure, and all those things. If at that point you suspect that this could be quite a severe attack, if you've taken their peak flow and it's less than 33%, or if you've got any of those signs of a acute severe or a life-threatening asthma attack, what you would do is you would warn ICU beforehand. What you then move on to do is the immediate treatment. So if you found that the O2 sats are low, you're going to give them oxygen. So high flow oxygen, 15 litres through a non-breather mask. You're going to try and maintain their sats so that they're between 94 and 98. You would give them a nebulizer, so you'd need to put on a mask that has like a nebulizer, and you'd give them 5 milligrams of that, and you'd nebulize that with oxygen. So you're giving them oxygen at the same time as you're giving them the nebulized salbutamol. And usually it's, I think the maximum is about 10 litres of oxygen that you can give with a nebulized mask on. Along with the salbutamol, you're going to give them steroids, because steroids are going to help with reducing inflammation that's going on in their lungs. So you, in an asthma attack, you give 100 milligrams IV, or you can give them prednisolone. So prednisolone's like an oral form, so it's a tablet. If they're really breathless and it's an acute situation, you will probably go for IV. If it's a severe or life-threatening asthma attack, you'd also add in ipratropium bromide, and that's also given through a nebulizer. Once you've started this immediate treatment, what you're then going to do is reassess them every 15 minutes. Because you're giving salbutamol, you're going to, like I said, you're going to give the salbutamol nebulizers every 15 to 30 minutes. You're going to want to monitor their ECG as well, because salbutamol can cause hyperkalemia. So you need to keep an eye on the ECG to make sure that there are no changes. You might at this point also consider magnesium sulfate to prescribe as well, if you're finding that they're not improving. So a handy way, because I know that there's a lot of medications that I've mentioned, so a lot of treatments and things, so a handy way of remembering it is the is it an anagram? I can't remember what it's called, but you know what I'm talking about. It's come up on the screen there. That's the handy way of remembering all the different things that you need to prescribe, and it's useful for exams to know. Okay, so a bit more on the management. So like I said, if you find that they're not improving, or that they're showing signs of like a deteriorating peak expiratory flow, if you find that their hypoxia is not getting better despite oxygen, if you find, again, like we said, the hypercapnias, if their CO2 levels are rising, if you find that they have an acidosis on their ABG is also part of the ATE assessment you would have done, or if you find that they've got like reduced consciousness, what you need to do is to refer them to ICU. There they would consider whether they need to start ventilatory support. So it might be that they use non-invasive, or decide actually they need to intubate them. You might consider a drug called aminophylline as well, and you might consider giving them the salbutamol via IV. If you find that actually they're improving within 15 to 30 minutes, what you would do is you would continue with the nebulized salbutamol every 4 to 6 hours. You would give them a course of steroids for about 5 to 7 days to continue with, so that's oral steroids, and you'd continue to monitor their peak flow and oxygen saturations. The point at which you can start thinking about discharge is if you find that, given interventions, within an hour their peak expiratory flow rate is back to above 75% of their best, you might then decide to discharge them with a follow-up appointment in outpatients. There are certain situations where you might not do this. Say, for instance, if they've come in at night, it might not be the best idea to discharge them at that point. If you've got any concerns about their compliance with their medication, if you're concerned that they live alone, or that they're pregnant, or if they've got a history of having like a near fatal asthma attack, or if they have really poorly controlled asthma, sometimes referred to as like brittle asthma, if there's like a wide variety in their peak flow values. Those are all situations where even if their peak flow came, back to over 75%, that you might still decide to watch and wait and keep them in rather than discharging them. Okay, so what we'll do now is we'll move on to managing an acute exacerbation of COPD. So the first thing we need to know is what the features are. So the way that it presents is it's an increase in the baseline symptoms that a patient has with COPD. So again, you're going to have a talk on COPD in general. So we're just going to focus on managing the acute exacerbation. So what they'll have is an increase in their level of dyspnea, cough and wheeze. What they might also have is with the sputum that they usually get with their cough, they might find that they have an increase in the consistency of that sputum. There might be like a change in the colour of the sputum. If there is a change in the colour or like the amount of sputum that they're getting, it's usually indicative of like an infective cause of this exacerbation. And they might also present hypoxic with like acute confusion. So the most common causes of an acute exacerbation of COPD are infective causes. So the two top like bacterial infections that cause exacerbation of COPD are H. influenzae and also strep pneumonia. The most common viral cause of an exacerbation of COPD is different types of rhinovirus, and I think that accounts for like 30% of all exacerbations of COPD. But yeah, the main ones are on there. Okay, so managing an acute exacerbation of COPD. So it's the same thing. You're going to start off with your A to E assessment and also your investigations. So in that, you're going to get their respirate, their O2 sats. You're going to do like a respiratory exam, like you're going to listen to their chest. You'll want to do the chest x-ray and do an ABG as well. So the way that you manage it is if they're hypoxic, you're going to give them oxygen. So the important thing to note is here your baseline is slightly lower. So in a COPD patient, you're going to be aiming for SATs between 88 and 92. So if the SATs aren't lower than 88, you're not going to be particularly worried, but you're going to give them oxygen if they are. Same thing again, you're going to give them a salbutamol nebulizer. You're also going to give them ipratropium bromide nebulized as well. And you're going to prescribe them some steroids. And those steroids, they're going to be taking for 7 to 14 days. So I think I was saying in asthma, it's about a week's course of steroids, but in COPD, it's 7 to 14 days that they're going to be on those steroids. Alongside that, if you suspect that the cause of their exacerbation is infective, so if they've got like a history of having like a runny nose and that kind of like cold-like symptoms before this exacerbation had happened, or if they've got a fever, or there are any other signs of like an infective cause, you're going to also prescribe antibiotics. And the antibiotics you prescribe is usually amoxicillin, but it's always based on the hospital trust's guidelines. And if you find that they're not responding to the steroids and nebulizers, then you would consider aminophylline. So if you've done all of this and you find that actually you take an ABG and their CO2 is still rising despite treatment, or if their respirate is above 30 or their pH is really low, so they're acidotic, then you might consider non-invasive positive pressure ventilation. So something like a CPAP or BiPAP, those are kind of non-invasive ventilation methods. The point at which you would consider intubating and ventilating is if you find that their pH, so on the ABG, is showing as less than 7.26, or their carbon dioxide is still rising despite being on the non-invasive ventilation, that's when you would consider intubating and ventilating. Okay, so what we're going to do now is move on to take a quick 5-second break, but we'll be moving on to pneumothorax and tension pneumothorax as well. Okay. So the pneumothorax is where you get air in the pleural space. So the air is between the lung and the chest wall, and this can occur either spontaneously or due to trauma. There are certain risk factors that increases your risk for developing a pneumothorax. Smokers are at an increased risk. If you have a family history of people who've had a pneumothorax in the past, typically like the textbook example that's always given is a young man who's tall and slender. Usually it's like a typical in an exam that you'd get that scenario. So they're at increased risk, and it's 5 times more common in males. Trauma as well, so trauma to the chest can sometimes cause a pneumothorax. So if someone's broken a rib, that can sometimes cause a puncture that could lead to a pneumothorax. If you have an underlying lung disease, that increases your risk as well, and also certain connective tissue diseases do increase your risk as well. So the way that you can, so just focusing on pneumothorax, not tension for the moment, the way that you can classify a pneumothorax is based on whether the person has an underlying lung condition or not. So a primary pneumothorax is where you get the air in the pleural space, but this occurs in a patient that has otherwise normal, healthy lungs. Okay? And a secondary pneumothorax occurs in a patient that has an underlying lung disease, be it asthma, COPD, cystic fibrosis, sarcoidosis, some kind of underlying lung disease. Okay? And tension pneumothorax, the way that this differs is it may occur following trauma, but what happens is you get like a defect in the pleura, and so you get flap being created, so the air can kind of come into that space, but the flap prevents it from coming back out. So what then happens is you get air coming in and the pressure in the pleural space increasing, and it's basically a medical emergency because everything kind of gets shifted and that air can't escape. So we'll go on to talk about how to manage tension pneumothorax in a moment. What we'll first do is talk about how to manage pneumothorax. Actually, we'll talk about the clinical features of both to begin with. Okay, so in a pneumothorax, it can be asymptomatic, or they can present with shortness of breath, pleuritic chest pain, so that's chest pain that's worse on inspiring, so taking in air, so breathing in. They can also have like an increase in their rest rate and an increase in their heart rate. Tension pneumothorax is the same in the sense that you can get sudden onset difficulty breathing and pleuritic chest pain, but you have additional signs as well that you find in tension pneumothorax. So you'll get, you can often get tracheal deviation, a displaced apex beat, and that's because you get a mediastinal shift away from the side of the tension pneumothorax. And the reason why it's away is because all that air is building up on that side from where the air is coming in, and so it pushes everything to the other side. You can also get hypotension and high rest rate and high heart rate as well with tension pneumothorax. Okay, so the management. So the first thing you need to do to decide is whether it's a primary or a secondary pneumothorax. Okay, and we discussed this is based on whether they have an underlying lung disease. Okay, so what we'll do is we'll first talk through the management of primary pneumothorax, and then we'll go on to talk through the secondary pneumothorax management as well. Okay. So with you've established that they don't have an underlying lung disease, so it's primary pneumothorax. The next thing you need to do is to decide on the size. So what you do is you take a chest X-ray and you'd see, is the size of the pneumothorax greater than 2 centimeters? If it is, then you're going to aspirate. If it's not greater than, the other important thing is whether they've come in with symptoms or not. So if, say, they've come in, the size is less than 2 centimeters and they're not breathless, what you're then going to do is you're just going to discharge them, and you'd follow them up in outpatients in 2 to 4 weeks. If the size is greater than 2 centimeters or they are breathless, what you're then going to do is you're going to aspirate the pneumothorax. Okay, and you do that with a cannula, and you kind of draw the air out. And if that's successful, and the way that you measure the success is if the size of the pneumothorax has decreased to now being less than 2 centimeters, or if they find that actually they're not as breathless as before, then again you can consider discharging them and reviewing them in outpatients in 2 to 4 weeks. If it's not successful, so they're still having symptoms, or and the pneumothorax is still greater than 2 centimeters, what you're then going to do is you're going to insert a chest drain, and we'll go on to speak about where the chest drain is inserted in a little while. Okay, so that's primary pneumothorax. If it's bigger than 2 centimeters or they're breathless, you're going to aspirate. It's not bigger than 2 centimeters, they're asymptomatic, you're going to discharge them. Okay, and then after you've aspirated it, If it's successful, you can discharge them. If it's not, you're going to put chest drain in. Moving on to secondary pneumothorax. Important thing to note is with secondary, we said that they do have an underlying lung disease. Therefore, there's not really you're not going to discharge them. So just remember that with primary pneumothorax, there is a chance that you might discharge them. Secondary, you're going to admit and observe them at the very least, okay, because they have this underlying lung condition, okay. So if they come in again, if the pneumothorax on the chest X-ray shows it's bigger than 2 centimeters, or they're breathless, what you're going to do is, instead of trying to aspirate it, you're just going to straight put the chest drain in, okay? This is for if they have an underlying lung disease, okay? If it's not bigger than, say they're not breathless, but the size of the pneumothorax is 1 to 2 centimeters, then what you're going to do is you're going to aspirate the pneumothorax if it's 1 to 2 centimeters, okay? If that's successful, then you admit them and observe them. If it's not successful, then you'd put the chest drain in, okay? And remember, aspirate is basically, it's not putting like a chest drain in and like basically draining the air. It's just basically trying to take out a little bit of air, seeing if that makes a difference, okay? So that's why if it's a big one, you're not even going to bother trying to aspirate it. You're going to go straight for the chest drain in secondary pneumothorax. If it's 1 to 2 centimeters, you're going to try and aspirate it. If that works, then you'll just admit them and observe them. If it doesn't work, you'll put the chest drain in, okay? If it's not 1 to 2 centimeters, meaning that it's less than 1 centimeter, then all you're going to do is admit them, give them high flow oxygen, observe them for 24 hours, okay? So, when you're inserting a chest drain, it's important for your exams to know what the safety triangle is. And so the borders of the safety triangle, this is basically where you're going to insert the chest drain, so it's the most safe and it's not at risk of damaging any structures. So the borders are the lateral edge of pec major, the lateral edge of lat dorsi, the base of the axilla is like the apex of the triangle, and then you kind of draw a line from the 5th intercostal space, and that's basically the area where you insert your chest drain. Okay. So the important thing also to note that I haven't actually put in the notes is after you've discharged them, there's certain things that you need to warn them about. So after they've had a pneumothorax, they can't go diving again, which is important to make sure that you let people know they're not able to go diving. And the other thing is, wait, let's move on to tension pneumothorax. Okay, so the management of tension pneumothorax, like I said, was it's a medical emergency. So what you're going to do is, if you suspect a tension pneumothorax, you're going to insert a large bore cannula into the 2nd intercostal space midclavicular line. And when you insert it, typically you hear like a hissing sound. That basically decompresses the pressure that's kind of built up. After you've done that, you still need to insert a chest drain. So you're going to go back and kind of go into that safety triangle and insert the chest drain. Okay, so I'll give you guys a second before I move on. Okay, so this is the last respiratory emergency that we're going to cover. So like I said, a pneumonia is also a respiratory emergency if they've come in with sepsis, but I'm pretty sure that you guys are covering pneumonia in another session. So a pulmonary embolism is where you get a blood clot in one of the pulmonary vessels. So the way that it presents is really dependent on what vessel is blocked. So you can have like a major PE where if one of the larger vessels are blocked, which can cause hypotension and like circulatory failure. But typically, the way that it presents, that you'll find in textbooks and things, is that they come in with pleuritic chest pain, with difficulty breathing, and hemoptysis. Those are the typical ones, but I think that's like 10% of patients with PE come in with those symptoms. So it is really varied in its presentation. The signs that people usually come in with are tachycardia, so a high heart rate, a high rest rate, fever, and crackles when you listen to their lungs. There are certain things that increase your risk of developing a PE, such as active cancer, so malignancy, surgery, especially surgeries in the pelvic, especially pelvic surgeries or lower limb surgeries, being immobile, having a previous DVT, or having some kind of blood disorder that increases your risk of getting clots. So antiphospholipid syndrome is one of those as well. Okay, so how you would investigate PE. Important thing to do first is chest x-ray. You don't necessarily, very rarely see anything on a chest x-ray that tells you that, that kind of indicates a PE, but it's more to exclude any other pathology that could be causing the symptoms that they presented with. An ECG as well, the most common sign that you'd see in an ECG with PE is tachycardia, so a high heart rate. The next thing you do is the 2-level PE Wells score. So I've put it on the right hand side of the screen there, so you can see the different criteria and the points that are assigned to it. It's really important that for exams that you learn this table, so you need to know what the clinical, so if someone comes in with like a DVT, that gives them 3 points on the 2-level PE Wells score. If it's more likely, if there's no other diagnosis that's more likely than PE, that's going to give them 3 points as well. So it's actually not that, if someone has a PE, it's not that difficult to get like over 4 points, which would make it likely for them to have a PE, if that makes sense. If they have like a DVT and there's no other diagnosis that's likely, then they've reached over 4. But yeah, you can have a read through the table, having a high heart rate, they've been immobilized for more than 3 days, they have a previous DVT, if they have hemoptysis or malignancy. Those are the criteria for the 2-level PE Wells score. So if they've got a score that's 4 or less, then it's classed as being like a PE being unlikely, and if it's more than 4, then PE is likely. And if PE is likely, then you're going to arrange an immediate CTPA. So that's the first line kind of imaging that you do for suspected PE. If you're not able to get a CTPA like immediately, what you then do is just treat it as a PE until you're able to perform the scan. So you'd give them low molecular weight heparin in the meantime until you can get the scan done. If their Wells score was 4 or less, what you'd then do is arrange a D-dimer test. If the D-dimer test is negative, it's highly unlikely that they don't have a PE, basically. But if it's positive, what you then do is arrange the CTPA. And again, if there's going to be a delay in getting the imaging done, you just give them low molecular weight heparin and treat it as a PE until you can get the scan done. CTPA is the imaging of choice in a suspected PE. However, it's not always suitable for everyone. So if you're allergic to, if you have like a allergy to the dye that they use, or if you've got problems with your kidneys, then you might not be able to have the CTPA done. Instead, a ventilation perfusion scan is done instead. And I think I have a slide a bit later on to show you the 2 examples. But going on to managing the PE. So first thing you'd need to do is, if they're ATE assessment, again, if they're hypoxic, you're going to give them oxygen. If they're in pain, you're going to give them morphine for the pain, and you're going to give them something to prevent the vomiting that usually comes with morphine. So you, like we said, you'd give low molecular weight heparin. The only time when you wouldn't give low molecular weight heparin is if you suspect that it's a massive PE. So if they've come in with like hypotension and like they're in circulatory failure, and you're thinking that actually we might need to, so if they're in shock, you're thinking actually this might be a really big PE and we might need to thrombolize them. If you think you're going to thrombolize them, then that's the only situation where you wouldn't give low molecular weight heparin. Instead, you'd give unfractionated heparin. Okay. Once you've kind of started that treatment dose, you'll also need to start warfarin within 24 hours of like getting your diagnosis of a PE. And you continue the low molecular weight heparin for at least 5 days at the same time as the warfarin. So it's like the low molecular weight heparin is like a cover, because in the first 5 days, warfarin can actually cause the blood to clot rather than having like a blood thinning mechanism in the first 5 days. So that's why you'd kind of cover the warfarin with the low molecular weight heparin for those 5 days, or until the INR is 2 or above. So whichever one takes longer to happen, that's one that you'd kind of go by. Okay. And the length of time that you'd continue the warfarin for is dependent on whether it's a provoked PE or an unprovoked. So if there's a cause behind why they had the PE, so if they were immobile or they just had surgery, then it's a provoked PE, you know what caused it. And so in those cases, you would continue the warfarin for 3 months. If it's an unprovoked PE, so that means you're not really sure why it's happened, you'd continue the warfarin for 6 months. Also, it's really important in an unprovoked PE that you consider, does this person have an underlying malignancy? Because it's not unheard of that actually this is sometimes a way that people with an underlying cancer present. They come in with a PE. And so if a person is over the age of 40 and they've come in with an unprovoked PE, what they usually do after they've kind of treated and managed them is investigate them for cancer. So they might do like a CT abdo-pelvis, they might do like a mammography in a woman. They might even test them for like thrombophilia, kind of to test if they've got like an underlying like blood clotting disorder that's caused them to have this unprovoked PE. And the other thing is, if you know that they've got an active cancer, instead of giving them warfarin, you're going to give them low molecular weight heparin for 6 months. Okay, and we've already discussed the fact that thrombolysis is what you'd give in a massive PE. The other important thing to note, I don't think it's actually coming up on the bottom of the screen, it's been kind of cut off, but if someone is having like reoccurring PEs, what you might, despite being adequately anticoagulated, what you might then consider is an IVC filter, which is like they kind of, they insert like this mesh type thing into the IVC, and that kind of stops any like blood clots that form in like the legs, in DVTs travelling up and getting into the lungs and causing recurrent PEs. Okay. Yeah, I feel like that flowchart that I've gotten is literally just lifted off of Oxford Clinical Handbook, so you can have a look at that afterwards. It's quite self-explanatory. Okay, yeah, so this was the thing I was talking about, the different imaging techniques. So there's CTPAs on the top, and on the bottom is the ventilation perfusion scan, so the VQ scan. Okay, so the next thing we're going to do, so those are all of the respiratory emergencies that we were going to cover. So what we're going to do now is we're going to move on to talk about lung cancers. So we'll talk about the different subtypes of lung cancers, different features, a little bit about the management. You don't need to know, like for the exam, you don't need to know like the different names of chemotherapy drugs and this and that. So I'm not going to even touch on that. So we'll talk about the different types of cancers. We'll talk about the 2-week wait pathway and kind of what symptoms kind of would lead you to kind of refer a patient or like get an urgent chest x-ray. So we'll talk about all of that. And what else will we talk about? And we'll also talk about mesothelioma as well, which is a type of lung cancer that's caused by asbestos exposure. Okay. Sorry, I'm taking like pauses on purpose because I know there's a lot of information and I want time for it all to sink in. I don't want to go too fast. Okay, so the main way that you can break down, there's also no way of me checking if I'm going too fast or not because I can't see your comments at the moment. Okay, so the main way that you can classify lung cancers are by non-small cell or small cell carcinomas. So we'll start with small cell lung carcinomas. So these make up like 10% of all lung cancers, and they're usually located kind of centrally in the thorax, and they arise from endocrine cells. APUD is just fancy. I can't remember what it stands for exactly, but it's basically endocrine cells. If you look it up, it will say that it's a type of endocrine cell. Okay, and so because they're associated with because they arise from endocrine cells, they're the lung cancer that's most associated with paraneoplastic syndromes. Okay, so these are syndromes where you get the release of hormones, like inappropriate release of hormones because of an underlying cancer. Okay, so some of the different syndromes that you might have is you might have the lung cancer, the small cell cancer, secreting ADH, which then causes, ADH is a hormone that causes water retention, and so what you might get is hyponatremia on their blood test results. You might have a small cell carcinoma that releases ACTH, which could then cause glands to become bigger. You might also get, because of the high levels of cortisol as a result of ACTH being released, you might also get hypokalemic alkalosis, which is also seen in Cushing's syndrome. Another thing that you might get is Lambert-Eaton syndrome, which I think you'll cover in neurology, but basically you might get some muscle weakness and things, which is associated with antibodies being produced to the voltage-gated calcium channels. So the important thing to note is just that these syndromes are all associated with small cell carcinomas, okay? And with this type of cancer, the prognosis is usually quite poor because it's an aggressive type of cancer and it spreads very early. And the way that they usually manage it is most cases are inoperable because it's aggressive, it spreads early, it kind of metastasizes all over the place. It's difficult to operate on. They do, though, now operate on very early stage diseases, so T1 to 2A they operate on. Don't worry about like the different staging for lung cancers because I'm pretty sure you don't need to know that for your exams. But yeah, as you can see, if it hasn't spread to any lymph nodes, they can operate on that, and that's they can be considered for surgery in those cases. But otherwise, the way that small cell carcinomas are usually treated is through a combination of radiotherapy and chemotherapy. Okay, so non-small cell carcinomas, there's three types. There's squamous cell, there's large cell, and there's adenocarcinoma. So the most common type is squamous cell carcinoma. Again, this one is usually centrally located. It's the type squamous cell carcinoma is the one that's usually linked to hypercalcemia. So if you have a question in the exam and it's someone that's got an obvious lung cancer and they've got high calcium, the cancer is most likely to be squamous cell cancer, and that's because it's associated with parathyroid hormone related protein. It's also strongly associated with finger clubbing, and it usually is seen on the x-rays like a cavitating lesion. Yep, and with this type of lung cancer, it's because it grows more slowly, it's not usually responsive to chemotherapy because chemotherapy works by killing fast-growing cells. And so because it's a slow-growing cancer, chemotherapy doesn't usually work very well on it. Okay, the other two types of non-small cell carcinomas are adenocarcinomas, which are usually located peripherally. One way someone once told me, a good way of remembering it is if you think of like an arena, it's like the outside, so adenocarcinoma is peripherally located. I don't know if that helps or not. It's also associated with gynecomastia, and it's the most common, this is important, it's the most common type of lung cancers in non-smokers. However, the majority of people with adenocarcinoma of the lung, they're still smokers. But if you were to look in the non-smoker population, then yeah, that's the most common type in the non-smoker population. Okay, and the last type is large cell carcinoma, and these are again usually peripherally located. They're very poorly differentiated. They might secrete the beta HCG. They usually have a very poor prognosis. Okay, so we've already spoken about how small cell carcinomas are managed. So we'll talk now about how non-small cell carcinomas are managed. Only 20% are suitable for surgery, and you know that surgery is like a curative option for lung cancer. Before they operate on you, what they need to do is they need to do a mediastinoscopy. So it's like a way of them looking to make sure that there's not been any spread to the mediastinal lymph nodes, because that doesn't always show up on CT. And then what they can do is they can, it says curative or palliative radiotherapy, and then it says poor response to radiotherapy. Sorry, that's a mistake on my part. It's poor response to chemotherapy, not radiotherapy. So just note that, and I'll change it before I send this the slides out. Okay, so there are certain things that are certain criteria for making you ineligible for lung cancer surgery. Okay, and so the way that they decide who gets surgery or not, like they do for any surgery, is to assess their general health. If they think that if the patient's really frail and they don't think they'd survive the surgery, then they won't offer the surgery. If the cancer is very, if the staging of the cancer is very far ahead, if it's spread, if it's metastasized, they probably won't offer surgery. If their lung function is not very good as it is, they probably won't offer surgery. If they've got SVC obstruction, so superior vena cava obstruction, these are all signs of like cancer that's progressed quite far, and so they wouldn't offer surgery in those situations. Okay, sorry, it feels like I've jumped around a bit with the slides, but I thought it was important to go through the different subtypes and their management before then talking in general. From here on out, it's going to be more general things about lung cancer, the features of lung cancer, and how you kind of, the different symptoms that would lead to referrals. Okay, so this is a lot more general from now on. Okay, so the features of lung cancer might be they present with a persistent cough, hemoptysis, which is blood in this so coughing up blood, so blood in the sputum, dyspnea, chest pain, weight loss, anorexia, superior vena cava syndrome, which is basically obstruction of the superior vena cava, which would then cause swelling of the kind of the arms and the face. It can cause like edema of the like around the eyes, and so that's kind of the symptoms that you'd find in the superior vena cava obstruction, is from where the kind of lymph nodes or the lung cancer itself are compressing on the superior vena cava. A pancreas tumour in particular would cause, so pancreas tumour is like a tumour in the upper lobe of the lung, would cause hoarseness potentially, from where it can kind of compress on the recurrent laryngeal nerve. Or it can also cause Horner syndrome, which is where you get lactosis of the eye, anhidrosis of the face, meiosis of the pupil, and that's typically seen in that upper lobe lung cancer. You can also get like a fixed monophonic wheeze when you're listening to the chest. You can get clubbing of the fingers, and you can get persistent cervical lymphadenopathy or lymphadenopathy in the supraclavicular nodes. Okay, so this is an important slide. So how patients are referred under the two-week wait referral scheme. So the way it works is there's 2 criteria for referring someone on the 2-week wait, and this is to see a chest physician. And if they're referred under the 2-week wait scheme for to go and see a respiratory doctor under suspected lung cancer if they've had a chest X-ray that suggests lung cancer, or if they're over the age of 40 and they've come in with unexplained hemoptysis. Those are the 2 criteria that would lead to a 2-week wait appointment to see a secondary care specialist. Okay, but before that, a lot of patients might not have had a chest X-ray, they've just come in with other symptoms. So what you would first do is offer an urgent chest X-ray, okay? And so you would offer an urgent chest X-ray to be performed within 2 weeks in a patient that's over the age of 40 and come in with 2 or more of the symptoms that I'm going to go on to list, or if they're a smoker and they've come in with 1 or more of the following symptoms, and that's a cough, feeling tired or fatigued, shortness of breath, chest pain, weight loss, or appetite loss. Okay, so if there's a patient that comes in, they're over the age of 40 and they're complaining of like a persistent cough and weight loss, then what you would first do is send them for a chest X-ray. That will be performed within 2 weeks. If the chest X-ray comes back suggesting that they have lung cancer, suggesting something that doesn't look quite normal, what they're then done is sent off to see a specialist in secondary care. Okay, so that's where you would definitely offer a chest X-ray for those symptoms. Okay, there are other scenarios where you might consider an urgent chest X-ray, and that's if the patient's over the age of 40 and they keep coming in with like recurrent or persistent chest infections, or they've got like cervical lymphadenopathy, or they've got like a monophonic wheeze or any other chest signs when you're examining them that consistent with lung cancer, or if they've got an unexplained like high level of platelets on their blood test, or if they've got finger clubbing, and that, you know, alongside being over the age of 40, you might consider getting them an urgent chest X-ray. And this is all relevant for like in like a GP setting if someone's come in. Okay, so lung cancer investigations that you do in lung cancer. So we mentioned chest X-ray is first line, but in about 10% of lung cancers, the chest X-ray actually comes back normal. That's why you usually need a CT scan, which is usually more accurate. What you also need is, in order to stage the lung cancer, you need like a biopsy. So a bronchoscopy is done and a biopsy is taken so that you can get like a histological diagnosis and also find out what type of lung cancer it is as well. And then you have PET scanning, which works by kind of looking at the glucose uptake, so basically how active the cells, the cancer cells are, and that's another type of imaging that can be done to investigate lung cancer. Okay, take a quick pause. Okay, so mesothelioma, again, this is a type of lung cancer, but it's a cancer of the pleural, of the mesothelial layer of the pleural cavity. Okay, and it's strongly associated with asbestos exposure. There are 3 kind of typical common signs that are seen with it, which are dyspnea, weight loss, and chest pain. You can also sometimes find that they present with like a painless pleural effusion. They might have pre-existing asbestos-related lung disease, or they might also come in with clubbing as well. They have usually have a history of asbestos exposure. It doesn't need to be like a really prolonged exposure with mesothelioma actually, and there's usually like a latent period of like decades between when they were exposed and when they developed the cancer. And interestingly, the right lung is more affected than the left. Might have to do with the size and the kind of the angle of the right bronchus. I'm not sure, but that's usually it's the right lung that's more affected. And it can metastasize to the other lung or to the peritoneum as well. Okay, the way it's investigated. So you do a chest X-ray. What you'd usually find is it's like pleural thickening and pleural effusion. You then do a pleural CT, and if they've got a pleural effusion, you would aspirate it and send it off to microbiology, microscope to get a culture and from the fluid. Okay, and so the way that you'd manage it is it's not curable. So what you do is symptom relief. They're usually eligible for industrial compensation, so you'd need to counsel them and make them aware of that. They can be offered chemotherapy and surgery if the cancer seems to be operable, but the prognosis is very poor and the median survival is usually around 12 months. Okay, I've just got a little bit as well on SVC obstruction, which we spoke about. It is an emergency, like we said. It's the obstruction of the superior vena cava. It can cause swelling in the face, neck and arms. It can cause visual disturbances and difficulty breathing as well. The way that it's managed is dexamethasone, which kind of like works to reduce the swelling. You can insert stent into the vessel to kind of keep it open. You can also do radiotherapy, radiotherapy and chemotherapy if it's a small cell carcinoma that's caused it, or just radiotherapy if it's a non-small cell carcinoma, to kind of reduce the size of the tumour so that it's causing less compression. So next thing we're going to go on to talk about is pleural effusions. We'll start off with what the features are. So it's typically the person presents with shortness of breath, so dyspnea, a non-productive cough, chest pain, and when you examine them, usually what you find is dullness to percussion. It's described as like stony dullness, reduced breath sounds on that side, and reduced chest expansion. So we've got an X-ray, chest X-ray, showing the pleural effusion on the left side, and you can kind of see the typical signs where you get like a meniscal line from like where the air fluid level is. Yeah, I can do that and then you'll be able to see. So you'll get a meniscal line forming the air fluid level. If it's a small pleural effusion, what you might get is like blunting of the costodiaphragmic angle, as well, costophrenic angle. As well, if it's a smaller pleural effusion. And depending on how big the pleural effusion is, you can also sometimes get like a mediastinal shift as well. Okay, so the way that you categorize pleural effusions are based on the protein level in the fluid. And so we categorize it as either being transudate or an exudate pleural effusion. So transudate pleural effusion has a protein level of less than 30 grams per litre, and it's usually caused by systemic factors, the most common being heart failure. And in heart failure, it's also usually that you get like a bilateral pleural effusion. And so the other things that can cause a transudate pleural effusion are having low albumin, and that could be due to something like liver disease or nephrotic syndrome or malabsorption. So you're not getting the protein that you need to make the albumin in your body, and so that's why you have low albumin. Hypothyroidism as well can cause a transudate pleural effusion, and also Meigs syndrome, which is where you get a pleural effusion in ovarian cancer. So those are all those are a list of transudate causes. If you go into exudate, an exudate pleural effusion is usually caused by local factors, and the protein level is over 30 grams per litre. Okay. The most common exudate cause is pneumonia, so some type of So it's an infection. The other infections that can cause an exudate pleural effusion are TB and subphrenic abscess as well. Connective tissue disorders such as rheumatoid arthritis and lupus can also cause an exudate pleural effusion. Certain lung cancers as well, pancreatitis, PE, and Dressler syndrome, which is a complication of heart attack. Okay, so the way that it's investigated. So you would do a chest X-ray, where you'd be able to see the pleural effusion. You would do an ultrasound to help you with aspirating the pleural fluid. Okay, and so that makes sure that you're in the right place. You might also do a contrast CT. So what would happen is you use your ultrasound to aspirate the pleural fluid. That fluid is then sent to check its pH, the amount of protein, the LDH levels, so that's lactate dehydrogenase levels, cytology and microbiology. That's all sent for the pleural fluid. So sometimes when the pleural fluid comes back and you know the protein level, it can be in the range of 25 to 35, and when it's that range where it's kind of like in the middle, and you're not sure whether it's a transudate or an exudate, what you then use is Light's criteria to help you distinguish whether it's transudative or exudative. Okay? And so Light's criteria says basically that it's more likely to be an exudative pleural effusion if the pleural fluid protein divided by the serum protein, so the protein in the blood, is more than 0.5, or if the pleural fluid LDH divided by the blood LDH is more than 0.6, or if the pleural fluid LDH is more than 2/3 the upper limits of the normal serum LDH. Okay, and this is just something that you kind of need to learn, Light's criteria for your exams. Okay. And so there are other things that you might find with the pleural fluid analysis. So if you have like a low glucose, if the pleural fluid comes back with low glucose, that's typical of TB and also rheumatoid arthritis. If it comes back with a raised amylase, that's typical of pancreatitis and also of perforation of the esophagus. If it comes back with like heavy blood staining, it's typical of TB, PE, and mesothelioma. Okay, and it's important to kind of know, to practice. It's not really able to do it in this talk because there's no way of you communicating back with me, but it's really important for you to try a few questions that kind of have like pleural fluid analysis, and yeah, I think you can get them on passment, but yeah, it's really important to kind of see if you can interpret them correctly. Okay. The other thing is if someone has a pleural infection, so it might be that the pleural fluid comes back like cloudy or purulent. In that case, you need to insert a chest drain to allow the fluid to drain. But sometimes someone can have a pleural infection, but the pleural fluid doesn't look purulent. So what you do is you check the pH. If you suspect that they might have a pleural infection, you check the pH, and if it's less than 7.2, you would insert a chest drain to allow the fluid to be drained. Because if the pH is less than 7.2, it's very likely that they have an infection. Okay, and again, I've put the safe triangle in again here because it's important to know, because that's where you can insert the chest drain for a pleural effusion. Okay, so the next thing we're going to talk about is TB. So the first thing is that everyone should know that it's bacterial infection caused by M. tuberculosis. The way that I've split it is we'll first talk about a primary TB infection, and then we'll talk about secondary TB. So primary TB is when you have someone who is not immune to TB and they're exposed to the bacteria. Okay, and this can be symptomless, and what happens is you get the formation of a gone complex, And what that basically is gone focus, which I've said is like a tubercle laden, so the kind of bacteria comes in and macrophages kind of attack it and forms like this ball. That plus a hilar lymph node, that's what kind of gives you the Gone complex. And this picture here kind of has some pictures of what that looks like on a chest x-ray. Okay, now in an immunocompetent person, so in a person with a working immune system, the lesion heals by fibrosis, and that's kind of it. But in someone who's immunocompromised, what can then happen is they get disseminated disease, and what they get is miliary TB, which looks like this picture here. It's like this kind of diffuse pattern in both lungs. Okay, so what we'll now do is talk about secondary or post-primary TB. So this is what happens if a host, so they've had TB, they've been exposed to TB in the past. If they become immunocompromised, so the immune system is not functioning well anymore, that TB can become reactivated. Okay, so where they've been exposed in the past and they've had like that TB, like that Gone complex form, if they become immunocompromised, that TB can become reactivated, and that usually happens in the apex of the lungs. And the reason why they become immunocompromised, so the possible causes of this secondary TB occurring, is if they're on any immunosuppressive drugs. That's why sometimes before people are started on certain medications for like their rheumatoid arthritis, they kind of do like a check, they check their TB if they've been exposed to TB in the past. Because if they have, there's this risk of it becoming reactivated. Other causes of them being immunocompromised and therefore developing secondary TB include HIV and malnutrition. What can also happen is you can get the TB infection not just in the lungs, but it can also spread to other parts of the body. The most serious of this being if it spreads to the central nervous system, you can get TB meningitis. If it spreads to the vertebral bodies, you can get Pott's disease. If it's can also spread to the kidneys and the gastrointestinal tract as well. Okay, so some of the features of TB infection include weight loss and kind of a low grade of fever, night sweats, malaise, having a pleural effusion. This is blood-stained symptoms, but it's supposed to say blood-stained sputum. And the onset of symptoms can be weeks to months from when you were exposed. And the people at high risk of TB are those that are HIV positive, people who are homeless, people in prison, those who suffer from alcoholism, drug users, recent migrants, particularly if they've come from a place where TB is quite prevalent, and asylum seekers. Okay. So the treatment for latent TB, so if it's found that they have latent TB, it's actually they should be offered two different types of treatment. They can either have 3 months of isoniazid with pyridoxine, and the pyridoxine is to it doesn't treat the TB, it's to counter some of the side effects that you get with isoniazid, which I will talk about. I don't think I put it in this lecture, but I will kind of go through some of those some of the side effects of each of the TB drugs as well. So they can either have 3 months of the isoniazid and rifampicin. This is usually offered to patients if they're younger than 35, and if you're worried about their liver. So that's why you don't want to give them 6 months of isoniazid, because isoniazid can cause hepatitis and problems with your liver. So this way you only give them 3 months of that drug with the rifampicin. Or you can offer them 6 months of isoniazid. The reason that you do that is if you're worried that the rifampicin could have an impact, and this is usually for patients who have HIV or if they've had a transplant. Rifampicin usually isn't a good medication for them to be on. Okay, so the way that active TB is treated is in total it's a 6 month 6 months that they're treated for, and in the first 2 months you give them all 4 TB drugs. So that's rifampicin, isoniazid, pyrazinamide, and ethambutol. So I'll quickly talk through some of the key side effects. The important thing to note is rifampicin is the one that causes orange secretion. So if in a question you get anything about the tears becoming orange or the urine being orange, that's rifampicin. That's the medication that's doing that. Isoniazid is the one that causes problems with the liver and also peripheral neuropathy, which is why pyroxidine is given, because that that's kind of to mitigate the effect that it has on the nerves. And then pyrazinamide, that's the one that can kind of cause, that's the one that causes gout. And ethambutol is the one that causes optic neuritis. It's the one that gives you problems with your eyes. Okay, so that's for the first 2 months, you give all 4 drugs. The following 4 months, you just give rifampicin and isoniazid. An important thing to know about is that sometimes, because this is like a notifiable disease, it's really important that the patients that have been diagnosed with TB, you know that they're actually getting their medication, they're actually being treated. And so sometimes what they do is directly observed therapy, where they have a 3 times a week dosing regimen. And this is usually for patients in certain groups, such as patients who are homeless or that you're worried about their concordance with treatment, or prisoners as well with active related TB. You'd prescribe you'd directly observe them taking the therapy. Okay, so now what we'll do is move on to talk about sarcoidosis. So sarcoidosis is unknown cause, why it happens. It's characterised by non-caseating granulomas. Typically, it's seen in young adults and people of African descent. So that's usually like in the vignette for a question. If they mention someone who's like a black young female, you would think of sarcoidosis if the question was about lung disease. Okay, so features of sarcoidosis. So it's not just, it's because it's a multi-system disorder, you kind of get systemic features. So you might get erythema nodosum, which is like, how to describe this, kind of you find them on the legs and they're like red circles. I've got some pictures of them that you'll be able to see, but you get erythema nodosum, you get bilateral hilar lymphadenopathy, which I've got a picture of an x-ray that shows that. You get swinging fever and polyarthralgia, so like pain in the joints. So this is the symptoms of, these are the signs that are typically seen in like an acute presentation. They might also present with weight loss, a non-productive cough, difficulty breathing. They might present with lupus pernio, which is like it's like a hardening of the skin, like hardening redness of the skin that's seen on like the nose and cheeks. I've got a picture of that as well. And they also have a raised calcium level. Yeah, okay, so you can see on here some of the pictures. So erythema nodosum in the middle. So on the shins, they've got like this, these like discrete red lesions. Lupus pernio is the one on the left here, where you can see like this hard red thickening of the skin, and then you've got bilateral hilar lymphadenopathy on the chest x-ray that you can see there. Okay, and then I've also listed a couple of syndromes which this is literally lifted off PassMed. So these are some syndromes that are seen with sarcoidosis. So you're going to get the slides to these anyway, so you can have a read through them. So Lofgren syndrome, I'm pretty sure that's the most common one you'll see. Bilateral hilar lymphadenopathy, erythema nodosum, fever, and polyarthralgia. And that has like a good prognosis. You also get some of the other syndromes which kind of present with like swelling and enlargement of the parotid gland, uveitis. Uveitis is like inflammation to do with the eyes. So you can have a read and commit that to memory. Okay, so investigations that you do with sarcoidosis. So you would check their ACE levels, and that's characteristically raised in sarcoidosis. Calcium levels are usually raised. Inflammatory markers, so ESR is raised in sarcoidosis. One of the ways they can stage it is through looking at the chest x-ray. So stage 0 is where the chest x-ray is normal. Stage 1 is where they have bilateral hyalulymphadenopathy. There's a picture on the slide here that will show you that. Stage 2 is where they have BHL and interstitial infiltrates, which you can see. Stage 3 is where they don't have bilateral hyalulymphadenopathy, they just have the diffuse infiltrates. And then stage 4, they've got fibrosis, okay, which is shown here. Okay, so the management, one second, I'm just going to... Okay, so the management of sarcoidosis is, the only management is it's steroids. However, not everyone with sarcoidosis requires steroids. There's certain indications for steroids. So if the patient with sarcoidosis has a chest x-ray that shows stage 2 or 3 of the disease, so if they've got bilateral hyalulymphadenopathy and diffuse infiltrates, or if they've just got diffuse infiltrates and they're symptomatic, so if they've got like shortness of breath, dyspnea, anything like that, non-productive cough, something that's causing symptoms, then you may offer steroids. However, if they're not asymptomatic, if they are asymptomatic and they've got like stable stage 2 or 3 disease and just like mildly abnormal LFTs, then they don't require treatment. The other thing is one of the side effects, one of the signs of sarcoidosis we mentioned was hypercalcemia. So if they come with a really high calcium level, then what you'll do is you'll treat that. So you'll give them, you treat it like you treat high calcium, so you'd give them fluids. So that's kind of like a symptomatic treatment. The other things that would require treatment is if they have neurological or eye or heart involvement of their sarcoidosis, then they might require management. So they might require steroids to help with that. Okay, so I'm pretty sure that's the last